Autoimmune hemolytic anemia. This is where the body decides to attack those pesky little red cells that seem to just be running all over the place. You should know by now that autoimmune disease is caused when the immune system fails to recognize the antigens that belong to us as self. And so it creates these autoantibodies against its own tissue. We're talking about an anemia here, which means the tissue we're looking at is the membrane of the red cell. So what happens is these autoimmune antibodies are going to coat the red cell. The FB portion is going to be attached to the antigen on the surface of the red cell. And the FC portion of the antibody is going to kind of be poking up and waving off into space. So as these antibody-coated cells go through the spleen and to a lesser degree the liver, the FC receptor on the macrophages that line the passages in those organs are going to bind with the FC portion of the antibody that's sticking off the end of the cell, and it's going to pull those cells out of circulation, and it is going to destroy them through extravascular hemolysis. Many of our hemolytic anemias also have a complement component, and that can cause destruction through the extravascular pathway, where the macrophage uses the complement receptor and pulls the red cells out of circulation. Or it can be the fact that complement is activated on the surface of the red cell, and we can actually see some intravascular hemolysis as well. We classify the autoimmune hemolytic anemias based on the temperature that we see the reactions at. The cold autoimmunes tend to be IgM mediated. The warm autoimmunes tend to be IgG mediated. But do remember that the immune system and the antibodies have not read the book, so we do get exceptions to every rule. The drug-induced tend to have a non-specific pattern, and the biggest thing there is to make sure that we don't confuse them with a warm autoimmune. Warm autoimmune hemolytic anemia tends to be significantly more severe, although it has been shown that a small percentage of donors, approximately 1 in 1,000, have a asymptomatic positive DAT, which means that their red cells are coated with antibodies, but it doesn't seem to have any significant effect on them. Obviously, if they're donors, their hemoglobin is good and they are in generally good health. So we're going to start with the cold autoimmunes. They react best at room temperature or below. Optimal temperature for many of these is 4 degrees centigrade. But since we don't do most of our testing at that temperature, we don't see a lot of them. We will see the ones at room temperature when we do immediate spin. And keep in mind that if they're not reacting at least room temperature, they're probably not reacting in the body. Some of these cold autoimmune antibodies can be quite persistent and quite strong, and we will see them go all the way through Coombs, and they can give us some pretty strong interfering reactions as we go along. About 15 to 20% of autoimmune hemolytic anemia is cold autoimmune. It is often primary or idiopathic, and idiopathic just means there's no known cause. And the way I remember idiopathic is we all know that path means disease, and that the idiot can't figure out what the disease is. That's just my mnemonic for remembering idiopathic. We also see cold autoimmune secondary to certain disease states. Certain things like lymphomas or other lymphoproliferative diseases. We also see cold immune in response to mycoplasma pneumonia or walking pneumonia, and to infectious mono or Epstein-Barr virus infection. Cold hemagglutinin disease is not common. The anemia, if present, is generally mild. Usually, the body can compensate for the lower level of hemolysis by increasing production a little bit. Uh, Clinical symptoms, we see acrocyanosis, and what this is basically anywhere at the end of the extremities, the fingers, the toes, the end of the nose, the ears, anywhere where you have a large capillary bed at the surface, you're going to see some discoloration. It can turn kind of purplish or blue, and if it goes on long enough, it can actually turn black. And what this is basically you've got increased hemolysis occurring at the extremities where this large capillary bed is being exposed to the cooler air. It's almost like frostbite is essentially what's happening there. For the same reason, that lack of perfusion in the extremities, you're going to also experience some numbness or some tingling. As with any hemolytic condition, you could see some jaundice if your hemolysis exceeds the rate at which you can metabolize the byproduct of bilirubin. You're going to see the skin turn a little bit yellow. The eyes and under the tongue, you'll see that kind of yellowish color. Many people with cold hemagglutinin disease often exhibit Raynaud's syndrome, and what this is when exposed to cold, their skin kind of turns purplish or blue. My niece has it. We're extremely horrible people because we call her the Smurf. I know, we're mean. She says, really, it's not painful. It generally is kind of itchy, just kind of annoying. And once she warms up, it goes away and it doesn't seem to have any lasting effect, at least at this time. You will see some hemoglobinuria if the amount of free hemoglobin in the circulation exceeds the renal threshold. You're going to see it spill over, so you will see some hemoglobinuria if the disease is bad enough. Treatment, often this is transient and it just kind of goes away on its own. It's clinically fairly mild. The treatment is basically just keep the patient warm. It will generally resolve on its own, or your body kind of reaches an equilibrium where it remains clinically unremarkable and doesn't really require any treatment. True CHD responds fairly well to corticosteroids. The immunoglobulins involved tend to be IgM and a very high titer. Occasionally, we will see people with both cold and warm autoantibodies. That's always a lot of fun. The specificities for our cold autoantibodies tend to revolve around the eye system. And if you remember, the big eye is on big people. Adults have big eye. And little eye is on little people. So infants and newborns have little eye. Anti-big eye is associated with mycoplasma pneumonia or walking pneumonia, and anti-little eye is often seen after a case of mononucleosis or other viral infections. And this is a fairly common test question, that big eye is associated with mycoplasma and little eye is associated with mono. The other specificity that we see fairly frequently is H and HI. And remember, H substance is the basis for all of our ABO groups. We see it most commonly in A1 and A1B patients, and that kind of makes sense because A1 and A1B have the least amount of H substance, so they are most likely to make the antibody. Then we have something we call a CAUS, which is a cold autoantibody of undetermined specificity. And basically, we don't go much past if it's an I or an H. And beyond that, we really don't care what it is. It's just a cold. So we don't spend a lot of time determining its specificity, and we just report it out as something cold. Protesting, what we usually see for these cold autoagglutinins, we see the autocontrol is positive at immediate spin and then decreases or disappears at 37. Like I said, we do have some, though, that hang around and can be extremely strong and can give us even 2, 3, even 4 plus reactions at AHG phase. So nothing is ever 100% certain. Most of the cold antibodies are totally insignificant, and the biggest concern is to make sure that they're not masking a clinically significant antibody underneath of them. If we suspect that anti-I is present, we're going to test a cord blood cell. So big people have big I, little people have little I. So if the patient has an anti-big I, the cord blood cell will be negative, and that will just tell us that the specificity is big I. Once we've determined what the specificity is and that it is just a cold, we can perform an absorption, and that's just a way of pulling that autoantibody out of the plasma so we can test what's underneath of it. And we do that using rabbit stroma, a product called REST, or rabbit erythrocyte stroma. And what they do there is they take bunny blood and they hemolyze it. Then they purify out just the remaining pieces of the membrane, because remember, the antigens are on the cell membrane, on the external surface. So if we just have that membrane, we mix that with some patient serum, we put that in the cold, and we let it just kind of sit there and react, usually 40 minutes to an hour. Then we take it out, we spin it down, we take off the serum or the plasma, and we test it to see if we've gotten rid of that cold reacting antibody. You can repeat the process a couple of times to see if you can get the cold antibody out. You just have to be very, very careful not to absorb out anything clinically significant. Then once we've ruled out that there are significant antibodies, we can use a pre-warm technique, and that's just what it sounds like. We warm up the red cells, we warm up the plasma, we warm up all of our reagents, and if the cold agglutinin is strong enough, we're actually going to wash it with 37-degree saline. So that's how we kind of get rid of these things. The most important thing to remember here is that we have to make sure that we rule out significant antibodies before we just make these cold antibodies go away. Now, PCH, or paroxysmal cold hemoglobinuria, this is a little bit worse than your standard cold hemagglutinin disease. This is a biphasic antibody, and that means that you have to get cold first and then get warm, and that's what causes things to pop. It has a specificity for the P antigen for some reason. The antibody that causes it is called the Doneth-Landsteiner antibody. So Doneth-Landsteiner goes with PCH. Essentially what we see is hemoglobinuria after exposure to cold. It is associated with viral infections, most commonly in children, and when it is associated as a post-viral complication, it's generally acute and it generally resolves itself fairly well. You just sort of treat the symptoms and monitor the child very carefully. The treatment for chronic is essentially the patient needs to stay warm. The only patient I know who ever actually had PCH diagnosed, they told her she needed to move somewhere else because Illinois is way too cold and she would have to stay in the house all winter long because she just has to stay warm. If she gets cold and then warms up, you get an acute case and you get severe hemolysis, and it can drop your hemoglobin rather precipitously. You can try corticosteroids, although they do seem to be less effective against PCH than most of the other autoimmune issues. If the hemoglobin gets low enough, we will transfuse. But we try not to transfuse any of these autoimmunes if we can avoid it. I have to explain the Doneth-Landsteiner test fairly quickly. The number one thing is that we're drawing serum, not plasma, and that it has to be drawn and kept at 37 degrees. you're going to put it into a water bath or put it into a heel warmer or something like that, but you've got to keep it at 37 degrees. You can't let it cool down. It has to be allowed to clot at 37 degrees. Then we spin it down and remove the serum from the tube. We're going to set up 9 test tubes, 3 sets of 3 each. We got A, B, and C, and 1, 2, and 3. So tube 1 of each set gets just the patient's serum. Tube 2 of each set gets the patient's serum and then serum from a normal patient to provide complement if it's necessary. Then the third set, the 3s, are all basically just control tubes, and we're just going to put the normal patient serum into those. And that's going to make sure that if we do get a reaction, that the reaction is actually due to what we're looking for and not some other thing that's going on. All of the tubes get an equal volume of 50% solution of reagent cells that are positive for the P antigen. We incubate all tubes for 90 minutes. The first set, all of the A tubes, go biphasic. So 4 degrees in an ice bath or the refrigerator for 30 minutes, and then into a water bath or a dry heat block for 60 minutes at 37 degrees. All of the B tubes get made cold, so we incubate those in an ice bath or the refrigerator at 4 degrees C for 90 minutes. And the control tubes remain at 37 degrees for the entire 90 minutes. In a positive Doneth-Landsteiner test, we are looking for hemolysis. So after we've got these incubated, we spin them down and we look for hemolysis, not agglutination. Hemolysis in A1 and B1 with no hemolysis in the other tubes is considered a positive test for Doneth-Landsteiner. And here's my cute little picture because pictures make it easier sometimes. So it's just the same thing we just talked about, but here's your picture. Okay, let's move on to warm autoimmunes. The warm autoimmune hemolytic anemias are going to react at 37 degrees and at Coombs. They are the most common type. Almost 80% of all hemolytic anemias are warm auto. It can be primary idiopathic or it can be secondary subsequent to various disease states. Again, your lymphomas and lymphoproliferative disorders, autoimmune collagen disorders such as lupus and RA can cause warm autoimmune hemolytic. Viral infections, especially Epstein-Barr, can induce this, and then a variety of other things, including that very, very dangerous pregnancy condition, which can do all kinds of terrible things to you. The immunoglobulins in warm auto, about 20% of the cases are IgG only. The majority of the cases and the most severe cases tend to be IgG and complement both, and that's about 67% of all cases. You see a small percentage of complement alone, and then you've got the rare warm auto that is mediated by IgA or IgM. These antibodies often have an Rh specificity for some reason. Occasionally they will react with all cells except for the Rh null. And obviously that's going to have to go to reference lab to find that out. The exact specificity is not necessarily vital, but we do often see an Rh pattern with these. We will also see certain high frequency antigens such as that KPB, the VEL, the U, right B, and GE. Occasionally we will see a clinically significant antibody, autoantibody, so like an auto anti-JKA or an auto anti-Duffy A. In my personal experience, where I have worked we have always given antigen negative blood. So even though the patient's JKA positive, if we see a JKA specificity to their autoantibody, we will give them JKA negative blood. It's not going to hurt them, and the hope is that it will increase the survival time in circulation for the donor unit. I have seen arguments to the opposite, that it doesn't really matter and that you shouldn't be wasting time on it. So, but in my personal experience, we have always given antigen negative blood just to be on the safe side. We also have the non-specific warm autoimmune of undetermined specificity. And again, that's when we just can't get a pattern to it, or it reacts with absolutely everything. Warm autoimmune hemolytic anemia is much more severe than the cold. You can have a mild case of it, and it can be extremely severe, where you have a precipitous drop in the red cell volume and in the hemoglobin concentration. The symptoms associated with the warm autoimmune tend to be symptoms that are associated commonly with anemias: weakness, dizziness, pallor, shortness of breath. Because it is hemolytic, if the rate of hemolysis exceeds the rate at which the body can clear the breakdown products, you're going to get a buildup of bilirubin, and that is going to lead to jaundice. During an episode of warm autoimmune, we're going to see hemoglobinuria. And these warm autos do tend to be episodic in some patients, which means they may be sitting there and everything's just fine, and they go along just fine for a period of time, and suddenly they just have gross hemoglobinuria, and we see massive hemolysis in vitro or in vivo. It may be precipitated by some sort of trauma or medical intervention, something as simple as a cold, but often these occur just as an idiopathic event, where you're going along, you seem to be just fine, and suddenly, bam, you're anemic as your system starts to chew up all of your red cells again. Because the warm auto is significantly more because the warm auto is much worse, we're going to treat this much more commonly, and we're also going to treat it much more aggressively. You can transfuse if the anemia becomes critical, but again, they really prefer you not transfuse if you don't have to. Those donor cells are going to have a shortened lifespan in the system, and it's just going to give you more cells to destroy, and it's going to increase the free hemoglobin and increase the problems that you have when you have a hemolytic condition going on. The other thing is that with these warm autos, it may be impossible to find a compatible unit. It may not exist. This is something that a lot of physicians don't understand. And unless you really understand blood banking, this is very complicated. But essentially, there is no unit out there. They're not compatible with themselves. Sometimes I put it, they're not compatible with human blood. So there's just not going to be a compatible unit. So what we transfuse is what we call least incompatible. And that means that we take the units and we cross-match them, and the ones that give us the weakest reaction are the ones that we're going to give to the patient. Even though there's not necessarily a true correlation between in vitro strength and in vivo reaction, that's the best we can do. Now, because these units are incompatible, the doctor is going to have to sign an emergency release. And basically, that is the doctor signing and saying, I realize this blood's not compatible. I realize that there may be complications because of the incompatible blood, but my patient's condition is such that not transfusing is more of a danger to the patient than transfusing something that is incompatible. So basically, the doctor's just signing off and saying, I understand that the blood's not compatible, but my patient is so sick that if I don't transfuse, it it's going to be worse. We can treat them with corticosteroids, although the problem is you have to keep giving increasing doses, and you will eventually get to a point where either the steroids are no longer working or the dosage of steroids is doing more harm than it's doing good. We can treat with intravenous immunoglobulin, and this is kind of an acute phase sort of thing. The immunoglobulin that we give is just nonspecific. It's just an IgG molecule that's floating around. And what happens is those Fc receptors on the macrophages will get saturated by this free floating antibody. And this reduces the rate of sequestration of antibody coated cells, and it decreases the rate of extravascular hemolysis. Now, once corticosteroids have failed and we can't keep it under control, they will move on to splenectomy. And if that fails and they have real difficulties, they can go on to immunosuppressive drugs. But immunosuppressive drugs are a can of worms. It often causes more harm than good. And like with all treatment options, you've got to figure out the best thing you can do to treat the disease without killing the patient. In vitro, in the lab, the autocontrol is going to be positive in either the antibody panel or the antibody screen or the antibody panel. We're going to perform a DAT, and if the DAT is positive, that means that there are cells coating, or there are antibodies coating the red cells. So if the DAT is positive, we're going to perform an elution, and I'll talk about those in just a moment, and the same with the adsorption. But it requires some pretty massive work to get this warm auto to go away so that we can look for the underlying clinically significant antibodies to make sure that we are actually transfusing blood that is as compatible as we can get it. The drug-induced anemias, I'm going to put you to chapter 21 for more significant detail. Essentially, certain medications will combine with the red cells to induce the immune system to make antibodies. The antibiotics, such as penicillin and cephalosporins, tend to adsorb onto the red cells, and then the antibodies are made to the drug membrane complex. Other drugs, Aldomet being the most common of these, adsorb onto the red cells, and then something makes the immune system make antibodies to RBC antigens that are next to the adsorbed drug on the red cells. These antibodies activate complement and lead to hemolysis of the cell of these drug-coated cells. These also show an RH specificity at times. Treatment of choice, stop the drug if you can. Again, you have to weigh which is worse, the slight hemolytic anemia or the severe hemolytic anemia, which can occur with some of these drugs, or the condition that you've been treating. So stop the drug and try some other medication if you can. If the reaction is minimal, you can try corticosteroids, but they do have a mixed efficacy depending on what's going on. All right, special techniques. The elution, basically, this is what we do when we have a positive DAT. So the antibodies are attached to the red cell membrane, and what we have to do is we have to remove them from that membrane using physical or chemical means, so that once they're off of the membrane, we can then test them against screen cells and panel cells to see what specificity they have and identify what antibody was coating those red cells. Adsorption is where we're going to take red cells that we know the antigen type and we're going to incubate them with our patient plasma to pull out some antibodies from the plasma so we can see what else might be in there with it. The easiest example for me to give is for absorption. If I have an auto anti little e, I could take a couple of little e positive cells, and I'm going to need more than one because remember, it's not just going to absorb out the little e, it's going to absorb out anything in there that has a corresponding antigen. So it's going to absorb those out, and then I can run those plasmas against a panel and figure out what was in there. The two methods can be used together to separate alloantibodies from autoantibodies or to separate alloantibodies from each other. The thing that I need you to remember from this is that elution removes antibodies from the red cell and absorption removes antibodies from the plasma. This is definitely reference lab work, and the only thing to take away from this long term is to remember that sometimes finding out what the antibody is and finding compatible blood can take many hours or even days to complete.